Good evening, everybody, and thank you for having me. I'm very fortunate to follow an excellent talk by Alex. And I think we are really, really lucky here in Toronto because we work so closely with our colleagues in radiation oncology and neurology. It's a very solid multidisciplinary team, and we all learn from each other, and I think that's a really positive place to be. So I'm going to talk a little bit about what is new in bladder cancer treatment and research. Some of it there's a little bit of overlap with what Alex said, but all the same, you can just take from it what you need to. So bladder cancer, as you heard, is the 5th most common cancer in Canada, 4th most common in men, and 8th most common in women. And we don't really understand why there's this difference in genders. At one point, we thought maybe it was smoking related, but as smoking rates have come pretty much similar, it's not all that. It's something else, and we're still trying to figure out why that is. The average age of diagnosis is 73, which means that patients tend to be a little bit older. They may have other problems like heart problems, diabetes, high blood pressure, and other things that can not only affect their ability to deal with their diagnosis and their illness, but also the treatments that we want to give them. The main risk factor is smoking, but not all patients who get bladder cancer are smokers. But I don't think we've done an excellent job in getting this message out. We've talked a lot about smoking and lung cancer, smoking and tongue cancer, not a lot about smoking and bladder cancer, and that's maybe something that we could do a better job of. But again, it's about 50%, so not everybody who gets bladder cancer at all is a smoker. Histologically, which means under the microscope, what do these look like, or what do we call them? So we tend to call them urothelial. That's a type of cell underneath, when we look in the microscope, what they look like. And this can be either pure urothelial, or it can have a little bit of other types of cells as well, other types of cancer cells. Or sometimes you can get what's called a pure variant, which is a different type of bladder cancer that behaves in a slightly different way and also is not included in many of the clinical trials, which means our data in these variant histologies is not as robust as it is with the standard urothelial. And of course, depth of invasion into the bladder wall is the key. So we talked about non-muscle invasive, meaning it's on the inner lining, muscle invasive, it goes into the muscle, and then finally metastatic is it goes right through outside the bladder as well. So this cancer, of course, can arise anywhere along the urinary tract, from sort of the mouth of the kidney. I will try to use this laser pointer. So it can arise from the mouth of the kidney all the way down along the ureter, can involve the bladder, and can also involve the bladder neck. So those are all the places where this cancer can originate from. And as I just mentioned, the depth of invasion, if you can sort of see it, I'll show a nice picture as well, a little bit bigger, I think, so easier to see. But this is non-muscle invasive, and it's just sitting on the inner lining here. And in the past, it used to be called superficial, but they changed the name because it was kind of like, superficial, it's no big deal. But actually, it can be a big deal. So that's the reason why, in part, they changed the name to what's called non-muscle invasive. Then you have here muscle invasive, and that's when it's starting to get into the muscular layer around the bladder. So the muscle around the bladder helps it to contract to get the urine out. So when it's starting to invade into the muscle and that layer, what we get worried about, and what I say to my patients is worried about the escapees, the little cells that are trying to get away, the things that you don't see, as Alex had said earlier. And then finally, you can have metastatic disease where it's actually going outside already, and that's metastatic, or NUC is the way that's referred to. So non-muscle invasive bladder cancer represents about 70%. So most patients will have non-muscle invasive bladder cancer. About 25% will have muscle invasive disease, and 5% will have metastatic disease at the time of presentation. But there can be movement between these categories. So a patient could have non-muscle invasive disease, but it can then recur and be muscle invasive when it comes back. And similarly, a muscle invasive patient, it can recur and become metastatic. So there's some potential for movement across the board. There. So the main symptoms, and some of you are aware of this already, being either a patient or being a caregiver, things like blood in the urine, frequency, urgency, pelvic pain. And then you can also get things like back pain and bone pain, and that's indicative of where this cancer likes to go. So it does like to spread to the bones, sometimes can spread to the lungs, you can get cough and shortness of breath, and sometimes you can just get a feeling of just not feeling so well, decrease in energy, decrease in appetite, and weight loss. And of course, these are fairly non-specific symptoms. You could, I had a cold the other day, or, so it's these things are happening over prolonged periods of time. It's really important that you do see your doctor. Because, seeking medical attention early may allow it to be discovered in an earlier stage, but not always, okay? So when we think about non-muscle invasive disease, as I mentioned, it's limited to the inner layer of the bladder, and typically it's been managed by urologists. So Alex would, be managing these patients with cystoscopy and BCG or chemotherapy into the bladder, all of those things. And generally treated with removal of the tumor or a TURBT, which is a transurethral resection of the bladder tumor. And sometimes you'll receive additional treatments into the bladder, and that's called intravesical treatments. And these tumors, unfortunately, sometimes do come back. So we need to be monitored. We need to monitor our patients really closely, and they need to be followed and scoped and made sure that things are okay when they're being managed. And one thing I'll say before I go on to muscle invasive, typically it's been urologists who've been taking care of these patients. But as we're getting some of the newer treatments coming into the field, we sometimes get to meet medical oncologists like myself or Dr. Jang to talk about other treatments that are coming along. And sometimes that's in the context of a clinical trial. So now when we talk about muscle invasive disease, it's extending into the muscular wall, as I said. You can also have microscopically extended into other places. And again, I say should because I really think this whole multidisciplinary care is important. It should be managed by a combination of urologists, medical oncologists, and radiation oncologists, so a multidisciplinary approach. And patients should be offered all the potential options that make sense. And it's interesting because we did a survey. It's interesting. We did a survey about 10 years ago. And what we found in that survey of patients across Canada and the US was that they weren't necessarily getting all the options presented to them. They weren't being told about the option of bladder sparing. They weren't seeing a radiation oncologist. And we've repeated that survey now. We're doing a little bit better, but I think we could still do a lot better in making sure that patients are getting all potential options presented to them. So in patients with muscle invasive disease, we feel that for now, that they should get chemotherapy first if they are eligible, if they can, if their kidney function is good, if they're strong enough. They really should get chemo first. And the reason for that is not only to go after the disease in the bladder that we see, but also the disease that we don't see, the microscopic disease, the escapees, the cells that are trying to get away and trying to set up a home in another organ. So those are the ones you want to get after first and foremost. And we like to do this before we do anything else because we can start fairly quickly and we don't want to have any delays. And sometimes what's actually nice is when we give chemotherapy first, we do a scan after a couple of cycles, we can actually see the disease shrinking. So that's really, really rewarding to see that. And then after the neoadjuvant chemotherapy, we then move on to local treatment. And that can be removal of the bladder or trimodality therapy. And you heard in Alex's talk that what we're starting to see is outcomes in appropriately selected patients are fairly similar between those two modalities. In the past, it used to be lose your bladder and that's it. But I think now we're starting to look at things in a bit more of a nuanced way, which I think is really great. And then this refers to the question that came up earlier for patients who've had chemotherapy or not, who've had their bladder removed. We've had a study looking at the use of immunotherapy. And I'll go into a bit more detail about immunotherapy in a moment, but the immunotherapy is nivolumab. And it's shown that in patients who get nivolumab, that it keeps the disease at bay for much longer and might improve overall survival as well. So that's starting to be adopted more and more in patients who get, ideally, they get chemotherapy up front. They then get their bladder removed, and then they get a year of immunotherapy to kind of keep things away. So that's sort of where the field is moving in patients who have their bladders out. Now, in response to your question earlier, which is an excellent question, we don't yet have the same level of data for patients who've had bladder sparing procedures. So those are being investigated in studies, but the number of patients getting bladder sparing is much lower than patients getting cystectomy. So studies are going to take much longer to accrue the number of patients to answer that question. But, theoretically, kind of makes sense, but we really need the data to tell us if that's what we should be doing or not. All right. And then what about metastatic disease? And this is what I treat a fair amount of. And it's really when the tumor has left the bladder and gone to other places and we can see it. So lymph nodes, lung, and bone are the most common sites that it can go to. And it's a very what we call heterogeneous, meaning from patient to patient, their metastatic disease can be very different. They can have a few spots in their bones, they can have a lot of spots in their lungs. It really is variable across the board. And this has typically been managed by medical oncologists, but I will argue that more and more there are situations where maybe there's one spot that's growing that we might ask our radiation oncologist to come in and say, hey, do you think you can radiate that spot? Do you think that's going to help the patient overall without necessarily giving them a different chemotherapy? So we really work very closely with our colleagues. And I've even had situations where there's disease that's growing in one spot, and I'll ask my urologist, I'll be like, do you think you can just take this one spot out? We may not cure the disease, but we may control the most active components of it. And so chemotherapy with the drug cisplatin has been around for decades and decades, the longest, like forever. And part of the reason for that is it's a highly effective drug at attacking bladder cancer cells. That's really the reason for it. And this is wherever it spreads to. And I get this question from time to time, if the bladder cancer is spread to the lung, will the chemo still work? And the answer is yes. So it kind of goes after bladder cancer cells wherever they are in the body, and it tries to eliminate them and get rid of them. And I think the challenge, though, in a metastatic setting is most people, we can't get rid of every single last cancer cell. And that's why we're not able to cure metastatic disease just yet. But there's about 5% of patients or so who are cured. And so that's why it's important to keep in mind that chemotherapy is important in this disease. So what we tend to do is after 4 to 6 cycles of treatment, which is, the treatment is given on day 1, day 8, we have a week off. So it's a 3-week period. After about 4 to 6 cycles of treatment, if the disease is stable and not growing, then we will often introduce immunotherapy, which is given every 2 weeks, and it's given indefinitely to try to maintain the response that we got from the chemotherapy. In some cases, though, the disease will not listen to the chemotherapy and it will grow. And in that situation, we give a different type of immunotherapy, again, to try to attack the cancer in a different way. So I sort of think about, having multiple types of arrows to go after the cancer in different ways, because the cancer can develop walls and it can build resistance. And then if the disease grows again, after the immunotherapy, we then have new targeted forms of chemotherapy that Alex alluded to that are going after specific things within the tumor. And those may work better, they may be more focused, more targeted, that type of thing. And I'll go into a bit more detail in a moment. And then, as I mentioned at the bottom, sometimes we can use some radiation. So we don't have to switch a different line of chemotherapy, we can actually radiate. So that might give a little bit of control over the disease as well. So chemotherapy, we know, may have side effects, but remember, so does the cancer, okay? So chemotherapy has reasonably good response rates, and in our world, we say about 45 to 60%. I know everybody would wish that was 100%, I do too, but it's still pretty good if the disease is growing and causing symptoms. And if the chemotherapy can control the disease, it can also control symptoms and can sometimes improve quality of life and even sometimes extend it. And the little picture there just shows you how you have the chemotherapy drug coming in here, the cancer cells are in red, and the chemotherapy drug can kill the cancer cells by damaging the DNA. It goes after the brain of the cancer cells to try to stop it from dividing and growing. And so that's often how chemotherapy works. And chemotherapy is given most of the time intravenously, and it's given as an outpatient, meaning you don't get admitted for it. You come in, you get your treatment, you go home. You go home with medications to help you if you have side effects. And usually, we are available if there's questions or concerns. There's someone on call 24 hours a day, every day of the year. And so that just helps get you through. And I think often it's the first cycle that's the hardest because you don't know what to expect. But after that, you kind of fall into a pattern. I know some of my patients have said once the chemotherapy is done, they miss some of their friends that they meet in the chemotherapy unit. So, it's very interesting how people adapt and get through difficult times in that way. And the Gemcis chemo, for example, is given on day 1 and day 8, and then there's a week off. So that's what a cycle is. The treatment can last about 2 to 4 hours. And then we give a bunch of different oral medications to control the side effects. And we have a lot of tricks up our sleeve. So if people are going through this and having a lot of symptoms, it's important that they let their doctors know so that we can adapt and change. And then a number of cycles depends on how people are tolerating it and how the disease is responding. And dose reductions are really important. And I think that that's the way we get people through chemo. We don't know what the perfect dose is for everybody when we start. So we often have to tweak the dose a little bit. And usually that doesn't impact efficacy, but it helps people get through the treatment. Now, what is immunotherapy? You've heard that term a lot. The oldest immunotherapy that we know is actually BCG, but we have a sort of new class of drugs. And what they basically do is help the immune system to recognize and attack the cancers. So the thinking is that the cancers are there, and the immune system goes along, tries to attack the cancer, and the cancer hits the off switch. So these drugs are meant to stop the cancer from hitting the off switch. So that's either at the side of the finger, it blocks the finger that's going to hit the off switch, or it's like putting a tape on the switch, so the switch is permanently on. Interestingly, the response rates with chemotherapy, with immunotherapy, actually a little bit less than chemotherapy. So people will often say, well, why don't I just get immunotherapy? I want immunotherapy. I don't want any chemotherapy. I only want immunotherapy. Well, the reason that we give chemotherapy is because it often gives us better control over the disease. And so that's why frontline, we tend to use chemotherapy. Sometimes it also takes a bit longer to work than chemotherapy. And right now, where we use immunotherapy is to maintain the response that we got from chemotherapy, or sometimes if chemotherapy doesn't work, immunotherapy might. And it's usually given every 2 or 3 weeks intravenously, and the side effects are very different. You can get rash, diarrhea, fatigue, can affect your thyroid function, so they're not without side effects. I have some patients who say there's no side effects of immunotherapy, but unfortunately there are. So it's important to, if you have any of those side effects, to make sure you're reporting that to your doctor, because sometimes the side effects can be really severe with immunotherapy. And here's just a picture to sort of explain what I was saying a moment ago. So you can see here the immune system, or the T cell, that's part of the immune system, it's one of the attacker cells. The T cell is trying to attack, the T cell, it's trying to attack the tumor cell. But through this PD-L1, this is a whole switch part of it, the PD-L1 receptor on the cancer cell hits the switch, the PD-1 switch, and turns it off. So down here, what you see is immunotherapy drugs that you see in green basically block this mechanism. So the cancer is not able to turn off the T cell is not able to be turned off, and that allows it to sort of, it sort of reawaken to the fact that the cancer is there. So that's how immunotherapy works. And immunotherapy, of course, can affect a number of different organs in terms of toxicity, and this just gives you a highlight of some of these. Can affect the skin, can affect the liver sometimes, not very commonly, can cause some diarrhea, we see that from time to time, and then some of the endocrine can affect the thyroid, and we're not exactly sure why, but that's something we keep an eye on as well, and some other can affect the lungs and neurologically, but fortunately the latter is quite rare. But the key is that we need to know about them, and then we can address them, and we use a lot of steroids to settle down the immune system a bit. So when it gets out of control, we want a bit of it going after the cancer, but we don't want too much of it. Okay, so the main ones, of course, being skin and diarrhea. Okay, now what's new, what's really exciting are these things called antibody drug conjugates. It's like a targeted form of chemotherapy. And Alex mentioned earlier, the target in this case with this drug is Nectin, and Nectin-4 is highly, highly expressed across bladder cancers. And so this is typically used in the third line after chemotherapy, after immunotherapy. What happens is that this drug kind of targets Nectin, and it brings along with it some chemotherapy. So the chemotherapy gets to where it has to go. And now more recently, in oncology, when drugs work in very late stage disease, it's then moved earlier and earlier. So this combination with immunotherapy and this drug called EV has been tested in the frontline setting, and the response rates are really, really exciting. And in fact, it's the first time we have seen something beating frontline gemcitabine. So, this was actually presented in Spain at the European Society of Medical Oncology meeting. And basically, when it was presented, my friend and colleague presented the results, he got a standing ovation. And I don't think we typically see that in our cancer meetings, but it was just a most emotional moment. And, we were so excited that finally we have a new combination in the frontline setting coming soon. So this drug by itself, before you add on the immunotherapy, has response rates upwards of about 45% or so. When you add it to immunotherapy, it's about 65%. It's got a unique set of toxicities, like everything, can cause rash, can cause tingling in the fingers and toes, and certainly can cause some diabetes. And dose reductions, again, are really essential to manage toxicities. It's important that we don't just sort of close our eyes and keep going if a drug is causing toxicity, but get to a point that the patient can tolerate it and derive benefits. So, and again, it's important to report the side effects. And this is just a schematic to show how this antibody drug conjugate works. And you can see here, this is the antibody drug conjugate. This is the drug. So what it does is it comes in to the cell, and then it gets sort of, digested and opened up. And then it releases this thing called MMAE that basically targets the DNA, targets the parts of the cell that are trying to replicate itself. And that's sort of like a very targeted form of chemotherapy, and it results in the cell dying. So this is a new drug that we're super excited about. Of course, in frontline, it's being given with immunotherapy. Yeah, I just said all that. All right. Another thing that we have in advanced disease is something called Erdafitinib, which targets FGFR. And FGFR is a little sort of a beacon that sits on the top of the cancer cell and tells it to grow. So if you block that beacon, if you block that receptor, the cell may stop growing. That's effectively how it works. About 15% of cancers have this receptor called fibroblast growth factor receptor on its surface. And so more and more it's important that we test tumors for the presence of this receptor so we know if this is a potential treatment. So it's of course used in the metastatic setting in patients who have disease that's grown. And when you use this drug, and it's our only oral drug that we use in this disease, it can cause a disease to slow down or to shrink. And it's often used in third or fourth line. So patients get chemotherapy first, immunotherapy second, they could get EV, and then they've got Erdafitinib. And it's interesting for me that, not that long ago, we only had one line of treatment, or maybe 2 lines of treatment. Now we're up to 4 lines of treatment with research ongoing. So hopefully we're going to get even more lines of treatment, just so that when the cancer becomes resistant, we have something else to do. And this is just an example of how this looks. So this is the receptor here, and it sort of gets the signal, these FGF comes in, it tells the cell, gives a signal for the cell to grow. This drug, Erdafitinib, comes right in here and blocks all the signaling, so then the cell is not able to grow. So this is another drug that's really quite interesting and that we're exploring, and that it's already approved in the post sort of chemotherapy and immunotherapy settings. Again, like any drug, it has its own set of toxicities. The most common ones are nail changes, can affect the nails. It can cause some eye disorders and can cause some diarrhea. So it's really important, again, that you report if you have any of these side effects. And again, dose reductions are really important to maintain quality of life during the course of these treatments. So really, I think I'm almost getting to the end. So management of metastatic disease has changed so much over the last 5 years. It's been really, really exciting. And, at the end of the day, though, each individual still has their own journey. So, what they experience is important, and what they experience may not be what other people do, but I think it's still important that we're all talking with each other. The treatments are often used in sequence to help overcome resistance, and sometimes we're combining drugs like EV plus Pembro, for example, in frontline. And what's been at the heart of all of this are clinical trials. And what's at the heart of clinical trials is patients like you participating in these trials. And my colleague, when he presented the results at ESMO with the big standing applause, one of the things he said that was very poignant was he wanted to thank all the patients that participated in the EV Pembro study, but also all the patients that participated in the trials leading up to that point, because it's been a lot of trial and error, a lot of learning, and we're so appreciative and at the same time dependent on patients to take that sort of leap of faith and get involved in trials. And it's good to look for available trials, ask your doctor if there's trials, and you'll never get less than what's standard of care. And that's an important point to keep in mind. If the standard treatment is drug X, on a trial, you will never get nothing. You will get X or X plus something, okay? So that's an important point to keep in mind. And then when we look at trials, there's different types of trials. There's phase 3 trials. These are large randomized trials, hundreds of patients. And often it's comparing a new drug against what we're doing already. And that's what happened with the EV Pembro that was compared to Jump Phase 2 are medium-sized trials, sort of about 30 to 50 patients or so. And usually everybody on that trial will tend to get the new drug. It's a smaller, we're trying to look for a signal of if we take it to phase 3. And then phase 1 trials are smaller trials. They're drugs that are just coming out of the lab, coming out of animal studies, early studies that are really looking for, can we give this drug to patients? What dose do we do? They're not almost looking for if the drug works or not yet. But if it did work, then it would go to phase 2. So those are just a little highlight about clinical trials. And sometimes trials give us or give our patients access to new drugs before they're available. Because of course the process of drug approvals are quite long. So sometimes that's a way we can, we can get in and have our patients see some of the newest and most exciting drugs that are in front of us. So I think, and then this is just, I give you a sense of sort of how it sort of plays out right now. Up front, patients usually get some form of platinum-based chemotherapy. In the green are the immunotherapy. And then you have things, the newer drugs all coming into play. Sesotuzumab is another antibody drug conjugate. We don't yet have approved. I have it approved here, but that's another one coming along. And then, of course, clinical trials. And that should actually span the whole thing. And then in patients who can't get platinum up front, there's also immunotherapy in that setting. So just it's more to just give you a sense of how the field is moving and what all is available now. So this is the first line. So first line EV Pembro will be coming. We're waiting Health Canada approval. I'm hearing maybe the end of the summer. You never know these timelines. But in the meantime, chemotherapy remains the standard of care. Frontline chemotherapy, second line immunotherapy, you get access to EV in third line. So the drug is still available. And again, at each step along the way, always ask the question, is there a clinical trial that you might be a candidate for? So that's it. So thank you for your attention. Happy to take any questions.
Thank you very much, Dr. Sridhar. Any questions?
That's a fair question. I mean, so it's a drug that goes into the DNA and really causes it to kind of get stuck. And so it's not able to duplicate itself and it's not able to make new cells. So that's effectively how it blocks cancer cells from growing and dividing and making new babies of itself. That make you go from a non-muscle invasive to muscle invasive. I don't know, maybe Alex is probably a good person to answer that because that's more sort of in his wheelhouse. But I think that, in patients who are having disease that recurs frequently. So they get treated, they have the tumor removed, then they get BCG, and then it comes back again. So I think that in patients like that, there's a fairly high risk of it becoming muscle invasive. Do you want to add into that, Alex?
Yeah, I mean, you remember the stratification between TA, the first line, and T1, which is the submucosa, and then T2, the muscle. And so the big question is, once you have a tumor which is high grade and goes into the second layer, is it a tumor which is on its journey to muscle invasion? Or is it simply that some tumor will go into the second layer and then decide, oh, I love it here, and just stay there, don't progress, and never go further? I think it's not fully elucidated. What we know, however, is that we can tease out what we call the bad players and the really bad players. And so patients who have a T1 rather than TA have a high risk of progression. TA usually is about 6 to 10%. T1 can vary in between, I would say, 15 to 35%. The second thing is that when T1 is accompanied by multifocal carcinoma in situ, we know that patients have a high risk of progression. Then we know that when patients have a T1, but they have also what's called lymphovascular invasion. So the disease decided to penetrate into some of these small lymph vessels that are like scaffolds to go out. This is another risk factor. And when patients have what we call variants, Kala showed you that the vast majority have pure urothelial cancer. But when you have some variants, we also, especially micropapillary and adverse, these are additional. And so it's not a black and white, it's shades of gray. When you have 1, 2, 3, 4 risk factors, and then you move to a high risk. But biologically speaking, even now, we don't have something which truly tells you that a T1 will progress.
Yeah, I think it's a good question. I mean, I think that the problem and the challenge is that we don't have a lot of data to say, we took these, unlike maybe mice, where we can do a little bit more controlled experiments in people, it's really hard to do that. That's one thing. The second thing is sometimes I worry a little bit that people, in the context of starting something like chemotherapy, if they're also doing something new on the side, what the impact of that is in terms of getting through the chemotherapy. And so, it's a very simple story, but I had a patient once, it's not fasting, but so they had their first cycle of chemotherapy and they came back and they said, every day I've been getting a headache. Every day at 2 o'clock I've been getting a headache. And I said to them, I go, do you drink coffee? He said, yeah, I stopped. And I go, maybe you need to start drinking your coffee again, right? So it's an example of how you have to be careful in terms of what you're doing in addition to the treatments that you're getting. I think we don't know enough about, does fasting work? Does it not? There's these concepts about sugar causing the cancer to grow, but then you have patients who are diabetics, for example, who doesn't necessarily mean that their cancer is going to grow because of sugar levels. I don't think we understand that as well as we could and should, and maybe need to be doing more research. But right now, it's a little bit early. But I think it's important, though, that if people are doing other things, that they do let their doctors know, just in case that there's natural things out there that can sometimes actually cause the liver to go off, or given in conjunction with chemotherapy or immunotherapy. We don't know if it's the treatment that we're doing. We don't know if it's the other treatment or some combination of the both. So I think there needs to be more research. It's a very interesting area, though.